Please, can you put your screen on slideshow, please?
Yes, I'm trying to do that now.
All right.
Just give me a minute. Okay. Good morning, everyone. Am I
Okay.
very audible?
Yes, you are audible. Please kindly hold on so that I can introduce the topic.
Okay, thank you.
All right. Thank you very much. Good morning, everyone. You're welcome to another edition of our academics session. Dr. Christiana Okibe from a senior registrar at High Foundation Hospital will be presenting ocular albinism. Dr. Christiana, you may start your presentation. Thank you.
Introduction. Good morning, everyone. Like was said, I hope I'm very audible.
Yes, you're audible.
Okay, thank you very much. So my topic is actually ocular albinism, but during my research, I realized that the ocular findings in both oculocutaneous albinism and ocular albinism are actually the same, just mild phenotypical differences. So I figured ocular anomalies associated with albinism would be a more suitable um, topic. Okay, so okay, so I'll be discussing using the following outline: a brief introduction, epidemiology, classification of albinism, pathogenesis, then the clinical features that we expect to see in ocular albinism, and management. Just a brief overview of management. So, albinism actually refers to, just give me a minute, trying to sort this out somewhere. Okay. Okay. So, albinism is actually a group of genetic conditions and it has diverse manifestation. So, that's what we mean by heterogeneous manifestation. And the main underlying defect is the disruption in melanin synthesis. So there's either disruption in melanin synthesis or reduced melanin synthesis. This can occur at different stages in the production of melanin, or there is an abnormality in melanosome maturation during development. So this leads to a variety of manifestations, both in the skin and in the eye. We'll be focusing on the manifestations in the eye. Any race can be affected by albinism, including animals also. So it's pretty much a defect in melanin in animals and human beings alike. So for the epidemiology, varying studies have shown a wide range of differences in data, but an estimation worldwide is about 1 in 5,000 to 1 in 40,000. The prevalence of albinism increases in societies where there's consanguinity, and in societies that are like primates societies that are excluded. Yes, that's the word. Societies that are excluded from or that stay isolated communities. So because of their small population, the prevalence will be higher if they have the gene in that community because of high consanguinity amongst themselves. So in broad classification, albinism can be classified into two groups. Oculocutaneous albinism, which is the most common one, which has manifestations in both the skin and the eye, and ocular albinism. Both are characterized by intracranial visual pathway misrouting and ocular signs, similar ocular signs such as fovea, hypoplasia, and nystagmus. So in oculocutaneous albinism, the defect is in the skin and in the eye, like I've said, and also in the hair. It's usually inherited in an autosomal recessive pattern, meaning both parents carry the gene for it to be passed on. And over 20 identified types have actually been discovered for oculocutaneous albinism. Another thing to note is that oculocutaneous albinism can be syndromic or non-syndromic. And the common syndromes that we know are the Hermansky-Pudlak syndrome, which has been found to be common in persons with Puerto Rican descent. We have the Chidak-Higashi syndrome, which causes bleeding and infection. We have the Guseli syndrome. These are rarer syndromes like the El-Jade syndrome. So these are rarer syndrome, not as common as the non-syndromic ones. Then we have ocular albinism. Two types of ocular albinism have been discovered in humans. We have ocular albinism 1, which is X-linked recessive. So that will mean that it's usually seen in males, though women can be carriers. Then we have ocular albinism 2, which shows less pigmentation compared to ocular albinism 1. And there have been studies that are trying to link ocular albinism 2 to infantile nystagmus. However, some studies also differ on that. So this is just an image of melanocyte. This is where the pathology, it occurs. So I just wanted to show us that. So we have the melanocyte, which is the cell where melanin is being synthesized, and we have the melanosomes, which transport this melanin. Now, so this is a Siamese cat. And if you're wondering why I'm showing the picture of a Siamese cat, we're going to see that soon. So next, we have pathogenesis. So I'm going to give an overview of the pathogenesis of oculocutaneous albinism, albinism in general, before I focus on the ocular findings. So for oculocutaneous albinism type 1, this is tyrosine related. And the deficiency is in the TYR gene that codes for tyrosine. So there's deficiency in tyrosine. Tyrosine facilitates the first two steps in the production. So that's the conversion of L-tyrosine to L-dopa and the conversion of L-dopa to L-dopaquinone. So in patients who have deficiency in tyrosine complete, they will be under the oculocutaneous albinism type 1. Under type 1, we have type 1A. This one is total. This is called tyrosine negative. So totally no tyrosine. If you do a hair bulb analysis of these patients, dopa will not be found to be negative. These patients are born completely fair and they remain fair throughout their lifetime, both their hair and the skin. Now, when we go to another type, we have type 1 has a subtype that has been discovered called the temperature sensitive subtype. Now, in this subtype, tyrosinase activity is inversely proportional to temperature. Okay, so that means that on the dark hair we form on polar extremities, while white hair remains on the core. That's the axilla, the pubic area. So, like the fingers, the hands, the ears, they will produce tyrosine and they will have some tyrosine function because of the cooler temperatures, and they will have pigmentation. So that takes us back to the picture of this cat. So this is a Siamese cat, and Siamese cat exhibits ocular cutaneous albinism temperature sensitive type 1. Okay, now we also have type 1B. This one shows reduced tyrosine synthesis. However, there is variable expression. So there may be some residual enzyme activity in type 1B. So these patients will have a milder clinical phenotype. So when we look at this image here, looking at the production of melanin, we have the eumelanin and the pheomelanin. So when it's total, the eumelanin is responsible for the black pigment that we see. So when it is absent totally, no pigment. But sometimes patients may have a defect in eumelanin, but they will have pheomelanin. So these patients that are up here, total uterine function is present, they will have zero melanin. But if it comes down and they're able to produce pheomelanin, these are the ones that will present with some melanin pigmentation. Now, when we go to oculocutaneous albinism type 2, this is the most common type, okay? It has the highest frequency in equatorial Africa. and it is attributed to a default in the P gene. So this protein stabilizes tyrosinase and enables transport of the melanosomal tyrosine. So mutation in this gene that code for the P gene will affect normal function of the melanosomes. Now, this patient will present with variable pigmentation. So another variant of oculocutaneous albinism type 2 is the brown albinism. So it's important to note that oculocutaneous albinism type 2 is the one that is commonest in Nigerian Ghanaians and also in African Americans, so people of African ancestry. I share similar, the chromosome 15, which is indicated similar to the Prader-Willi and Angelman syndrome. So this is for ocular albinism, which is my main topic. The defect in ocular albinism is on the GPR143 gene. So that's where the mutation occurs. Now, this is responsible for when the defect occurs, the melanosomes that are produced are abnormal. They have reduced motility, so therefore their function is reduced and they are reduced in number. So type 1A, like I said, they have two types. Type 1A is also called the nettleship fault ocular albinism, and a type 2, ocular albinism type 2 is called the Allen Island. Okay, so let's talk about the ocular features that we see in albinism. So like I said earlier, the ocular features in albinism are the same in both oculocutaneous albinism and ocular albinism. And oculocutaneous albinism, like we saw, the patients will have both expression in dermatology and ocular. So they will have both the skin defect and the eye defect. Reduced pigmentation generally. So their hair, their eyes, their skin, reduced pigmentation, their retina, reduced pigmentation. While in ocular albinism, these patients have a localized genetic mutation on the GPR143 gene responsible for melanosome maturation. So the defect is only in their eyes. So that's why it's called ocular albinism. However, the clinical manifestations in the eye are the same between the two. So I'm going to start with the first one, which is reduced visual acuity. So in this patient, the etiology in albinism in the eye, ocular manifestations of albinism will start from the reduced pigment in the retina. Okay, to start from the foveal hypoplasia, the optic nerve misrouting. These are the major, and then the iris translumination defects. So I'm going to go through them one by one. So reduced visual acuity is common to varying degrees, and it is related to the level of foveal hypoplasia. So it has been saying that the melanin is a strong stimulator for retinal development right from the embryology stage. So the absence of melanin does not drive the production, the correct maturation of the retina. And this will lead to the foveal hypoplasia that is common across ocular albinism. Now, when we want to check visual acuity in these patients, it's important to note that they have a high risk, they will have glare because of the iris translumination defect, and this may cause reduced visual acuity measurement. Refractive errors. So refractive errors are common in albinism because of the same reason. Because of the foveal hypoplasia, a metropisation that happens, when the baby is born, they are hypermetropic, and the eye still grows up to the age of 7. So we expect them to, the eye is going to attain emmetropia. So now this foveal hypoplasia does not allow, and the optic nerve abnormal crossing does not allow for this proper emmetropization of the patient of the eye, and this will lead to refractive error. So I did some study and trying to get the type of refractive error that is common. And there was a study done at Aminu Kano Teaching Hospital, and this found that the incidence of refractive error for patients with all type of albinism, hypermetropic astigmatism was the highest, followed by myopic astigmatism. And refractive errors are commonly associated with it, and hypermetropia has been shown to be the most common, probably because they don't that emmetropization does not continue in them, so the eye tends to remain hypermetropic. Now, the nystagmus also plays a role in the refractive errors of this patient because of the unstable movement of the eye and the perception of the image on the retina. The strabismus can also be seen in this patient. About 71% of them present with strabismus, with esotropia being more common. Next, we have anomalous head posture, which is not uncommon when you have either nystagmus, strabismus, or high refractive errors. Then we have the iris hypopigmentation and transillumination defect. Because of the lack of pigment in the iris, there will be transillumination defect in this patient, high risk of photophobia, and we can see this on slit lamp examination in this patient. We can see through the iris because of the lack of pigment in this patient. This is a significant cause of photophobia and glare in this patient. Next, we have nystagmus. Okay, next we have nystagmus. Nystagmus can be seen as it's one of the earliest signs that is seen in patients with especially in ocular albinism, where the skin appears to be normal. So nystagmus is one of the earliest. So nystagmus in a child, the fundus must be examined. Then the nystagmus is due to the abnormal visual development caused by the fovea hypoplasia, very important, and misrouting of the optic nerve at the optic chiasm. Now, when this happens, the patient usually presents with conjugate pendular or jet type nystagmus. And the nystagmus, the amplitude of the nystagmus will reduce as the patient ages. And this could be due to compensatory mechanisms that the patients develop, which reduce as the brain attempts to normalize vision, and this may dampen the amplitude of the nystagmus with time. They have reduced stereo acuity and stereo vision, also because of the optic nerve misrouting. So for the retinal pigment epithelium, decreased melanin will cause the characteristic albinotic fundus. This allows us to visualize. So from this fundus image, we can barely see the fovea pit here. There is marked display of the choroidal vessels. So this is a classical albinotic fundus, and reduced pigments also leads to severe photophobia. Now, foveal hypoplasia. Foveal hypoplasia, like I said earlier, melanin has been shown to be a trigger for normal retinal development. So when it is absent, the development of the fovea is impeded. And this is what is leading to the foveal hypoplasia. And fovea is important in development of vision, of good vision. So in most patients, there may be complete absence of the fovea pit or a partial development of it. It is prevalent in up to 94% of patients, and we can visualize this also on OCT. I'm going to also show a picture of the OCTA. Early visualization and this also is important in diagnosis in ocular albinism also. When you see this, you know that, okay, there is not just nystagmus that is present in this patient, there's reduced pigmentation, so we have to look at the hypopigmentary disorders, and albinism is top of that. This is an image of a patient that was done at our center. The fundus photo shows showing the choroidal vessels very prominent, and the absence of the foveal pit. This is same again. When we look at the OCT here, we cannot see the depression of the fovea. When we look at the OCTA, the foveal avascular zone is barely delineated. It is barely seen because the stimulus for the development of the foveal avascular zone is the pigment. And when it is not present, that development is halted. And this is how the patient will present imaging. This is another image of retina of a patient that was done also at our center, OCT, showing that the fovea pit is not present. Now, when we come to the optic nerve, there's abnormal routing of the optic nerve. So we know that there's deposition at the chiasm, the nasal fibers cross, and the temporal fibers stay on the same side. So when we look at this imaging, if the temporal fibers that are supposed to stay on the same side, a large portion of them also cross. So up to 80% of them cross. Normally at the chiasm, 53% of the fibers from the nasal hemiretina will cross over. while 47% will remain uncrossed at the temporal side. But however, in albinism, up to 80% can cross over. So now when this crossover happens, the normal deposition of the optic fibers at the chiasm allow for the development of stereoacuity. It allows for spatiotemporal development. It allows for binocular vision, proper binocular vision. That's why the eyes of the human are in front. When we look at primitive rodents like the rats and the guinea pig, we see that their eyes are on the side. But we, because we have stereo acuity, we're able to perceive depth and we're able to compose composite image, one image, our eyes are in front. Now, when this happens, this misrouting, it leads to that's what leads to one of the causes of the poor vision that they have, leading to the nystagmus also, because the development is halted. Now, and this also leads to abnormal findings on the visual evoked potential. Other optic nerve abnormalities in this patient will be smaller cup to disc ratio. They barely seen cups in this patient, very small optic nerve head and cup to disc ratio. Reduction in the thickness of the peripapillary retinal nerve fiber layers. And this is also another consistent finding. So this is a brief summary of the ocular findings that are seen in patients with ocular albinism. I'm just going to summarize the management of these patients. So management will start with a good history and physical examination. It's important to identify the inheritance pattern and also to do genetic testing where it is available, especially in clusters with high incidence. And that will help in counseling, genetic counseling for prenatal counseling. We are to look for systemic associations if it is present in syndromic cases of oculocutaneous albinism. That may require multidisciplinary management to improve the prognosis and the life expectancy of these patients. We also know that in oculocutaneous albinism, dermatology is important because of their exposition to UV rays and predisposition to wound malignancies. Orthoptic assessment and refraction and myopia management, all these are aimed to improve the vision, to give the patient the best possible corrected vision that is available for them. So refractive correction, glasses, photochromic tinted glasses to reduce glare. Albinism, however, is a clinical diagnosis, and when we see a patient with oculocutaneous, it's usually straightforward diagnosis in our, especially in our setting where it's a bit common. But for ocular albinism, a child presents with nystagmus or poor vision. It's important to do fundoscopy, and when we see these signs, then imaging may be needed to confirm the diagnosis. Surgical management may be required if the abnormal health to achieve a null point, to optimize vision at a null point in patients with abnormal health positions and nystagmus. I think that this is the end of my presentation. Thank you for listening. Do we have any questions?
Thank you very much, Dr. Christiana, for the detailed presentation. I think you've done justice to the topic. You've discussed the ocular anomalies in albinism. You classify the albinism into type 1 and type 2. The oculocutaneous, you classify the albinism into oculocutaneous albinism and ocular albinism. And the oculocutaneous albinism was classified into type 1 and type 2. The type 1A, type 1B, and then type 1 TS, which is the temperature sensitive oculocutaneous albinism. You also told us about the pathogenesis, the various abnormalities that can occur, the absence of eumelanin, and then the absence of pheomelanin. Thank you very much. And also, you also talked about the ocular features, including the reduction in visual acuity, the various causes of reduced vision, the refractive errors that can occur in them. Usually, they tend to have hypermetropia, and also nystagmus due to unsteady image on the retina, then also strabismus, which are some of the causes of refractive error in this patient. Also, you talked about high-risk hypopigmentation because the iris is usually translucent, so they have a lot of photophobia and glare. Also, you talked about retinal pigment epithelial hypopigmentation, which is may also be described as the albinotic fundus, in which there is appearance, the prominence of the choroidal vessels. Also, they also have foveal hypoplasia, which can be seen in 94% of the patients. Also, the chiasma misrouting, which is they have more of crossed fibers in the optic chiasm. About 80% of the optic chiasm, or fibers in the optic chiasm are crossed, resulting in poor development of their stereo acuity. You also made mention of some abnormalities of the optic nerve head, which include the small optic nerve, the small cup to disc ratio, then decreased thickness of the retinal nerve fiber layer. Thank you very much for the detailed presentation. So we now welcome questions and comments from the audience. Please, there are no questions in the chat box presently. So if you have any question, please raise your hand and question. If you have any questions or comments, please signify by raising your hands, and then we can then call you to ask your question. Okay, there are no questions yet. Let's give, I don't know. If you have any question, please feel free to signify and ask your question.
Is that a comment? I don't know. I couldn't raise my hand. I don't know why. This the icon here. Okay.
Please go ahead, please.
Okay. Thank you very much, Dr. Christiana, for your detailed presentation. It was quite insightful, especially around issues around the pathogenesis and the optic nerve crossing and all that. Well, I think we could have, there are some things I felt were missed in the management. Yes, you talked about history, you talked about examination. Albinos do fairly well with refraction. And for those who do not do well or who are not, well, they do fairly well with refraction. So refraction is a crux of their management. Most of them, the young, part of most of their main complaint is difficulty seeing the board in the class. They will need to stay in front. Then outside the regular refraction, a good number of them, they among the people that have the best outcomes when they undergo low vision assessment. We know what the definition of low vision is. So any of them that falls within that proportion of low vision, after refraction and person's VA is still less than 618, they can have low vision assessment. And of all the patients that usually have low vision assessment, especially for those that use telescopes, young albinos do best from my experience with the use of telescopes. In class, they are the ones that, when you see an adult that does his work outside, you tell him you want to give me a telescope, you will not be happy. But children that have issues seeing the board in class or seeing slides in church, with their glasses on, with or without improvement, especially when it's less than 618, when you give them a telescope, it brings them close to 0.3. That I'm talking of logMAR chart now, around 0.69612. So they're among the best, have best outcomes when you give them telescopes. That's for distance vision. They also do well with some other forms of low vision devices for near vision. These are very good, important part of the optical management of albinism.
Thank you very
much. Thank you very much for that contribution.
Yeah, so we have some questions in the chat box.
Yes.
Yeah, so Dr. Abdulkarim is saying that what are the differentials of ocular albinism?
Okay, So for the differentials of ocular albinism, we'll be looking at disorders that will cause nystagmus, disorders that will cause hypopigmented fundus. So we can start with, let's say, the congenital stationary night blindness. These patients, their visual acuity will be reduced, non-progressive, and they will present with nystagmus. Occasionally, but they will have normal color vision. Their fundus will be normal, so they will not have, they will have nystagmus, but their fundus is normal. They will have abnormal dark adaptation, defective dark adaptation. Another one we have is infantile nystagmus, and this will also occur pretty early in life, probably within the first 6 months of life. However, the skin is normal, no hypopigmentation, normal fovea, or low-grade abnormalities in the fovea. I think another one will be the levers. This nystagmus had birth, roving eye movement. They may have other signs, but their fundus also we expect. Okay, so that another differential will be levers. I think I've said the congenital stationary alignment. So these are the top most that I have for differential diagnosis for ocular albinism.
All
For
right.
for imaging in ocular
Okay.
albinism, personally, I would say ocular albinism is a clinical, we can diagnose it clinically even with fundoscopy. But OCT, fundus photo will be good to show the patient also, and for us to also see clearly. We will see the abnormalities of the fovea hypoplasia, the lack of the fovea pita, and we'll see the very clear choroidal vessels. Because of the lack of pigment, the choroidal vessels will be very visible. The OCT will show that there is no depression of the fovea, and the OCTA will show the absence of the fovea avascular zone. So the role will be to confirm our diagnosis, which we know also. The other investigations that may be a bit more specific to albinism would be like the visual evoked potential or the genetic testing, which another person has asked if genetic testing is available at my center. Currently, no. We do have, however, have the ARG, but we don't have the genetic testing. Can I shed more light on the classification, especially with types under Ocular? Sure. Let me, maybe I will share my screen again so that I can show that slide. Okay. Okay, so okay, so for albinism, the defect is in the, give me a minute then to move it away. Let me see. Okay, can we see my cursor? Because I'm trying to arrange it very well so I can see the whole screen.
Yes,
Okay.
you
Okay.
can see. Thanks.
Thank you. So for oculocutaneous albinism, okay, for albinism, we have oculocutaneous and ocular albinism. Oculocutaneous, as the name implies, will be ocular and cutaneous. So there will be hair, skin, eye manifestations, lack of pigment generally everywhere. That's for oculocutaneous albinism. For ocular albinism, we'll have normal skin, normal hair, however, hypopigmented fundus. The fundus is where the pathology is. It's only in the eye, from the iris, sorry, to the fundus. Sometimes the iris may not show, but ocular albinism or can be a cause of light iris color and also oculocutaneous albinism type 2. So those are the major, that's the broad classification. So to go under the individual classification, for ocular albinism type 1, so there are many types of oculocutaneous albinism, by the way. During my research, I probably saw about 13, and they have said they're up to 20. So there are so many, but I'm just going to talk about probably 4 of them. because there are so many, and the whole point of the numbering is when a genetic mutation is discovered. So it may be only in a very few people, but the fact that it was discovered, they will just add it to the number. So I'm talking about the most common and probably the oldest discovered ones. So oculocutaneous albinism type 1. So this is hair and skin that we're talking about. Type 1 is related to tyrosine, okay? So there's a mutation in the tyrosine, in the TYR gene that codes for tyrosine. That's where the defect is in type oculocutaneous albinism type 1. Where does it happen? So tyrosinase, in the gene that codes for tyrosinase catalyzes the first two steps in the production of melanin. So it catalyzes the conversion of L-tyrosine to L-dopa and L-dopa to L-dopaquinone. So in type 1A so we're under type 1 now, oculocutaneous albinism type 1. In type 1A, so type 1 I said is related to tyrosine. It's related to tyrosinase deficiency, the gene that codes for it. So now in type 1A, total absence of tyrosine. There's total absence of tyrosinase activity. In type 1A, total, so the protein that is coded, is a defective one. So the body just degrades it. So there's zero tyrosinase activity, so zero melanin production. That is type 1. This is the most severe expression of albinism. So that is type 1A. Now we have type 1 temperature sensitive. So this is why I showed the picture of the cat for someone who asked. In this subtype, the tyrosinase activity is related to temperature. So in cooler areas, they have darker hair. In cooler parts of this is not common in humans, or it's common in cats, but I just put it there since it's in the picture that I was using. So since in the parts of their body that are cooler, that are far away from the core. So the core will be the axilla, the pubic area. These are places that are warmer. So those places will remain white. But in the peripheries that are far away from the core of the body, those places will get dark. So that is TS, temperature sensitive. Now we have under type 1 again, we have type 1B. This one has reduced tyrosinase activity. So not total absence. The mutation is still in the same gene, but it's reduced activity of tyrosinase. So they will have variable presentation and pigmentation in their skin and in their hair. So this is a milder phenotype. So that is for type 1. Type 1, tyrosinase. Now we go to type 2. Type 2 is a defect, that's oculocutaneous albinism type 2. This is a defect in the P gene. Okay, so this gene, it stabilizes the transfer and the production of melanosome. So the melanosomes, we know inside the melanocyte where the production of melanin takes place. So this P gene is also now called the OCA2 gene, but that is where the mutation is. This is the most common one in our part of the world, in Africa, in Nigeria, people of African descent. So that is for type 2, oculocutaneous albinism type 2. So these ones will not have 100% lack of pigment. They will also have variable pigmentation. Under type 2 is where we have if you look down here, you see bokeh. So this just means brown albinism. So it's a type of type 2. Now we go to type 3. In type 3, the mutation is in the TYRP1. So that's where the mutation occurs. So let's see. So this protein here, this TYRP, so tyrosinase related protein 1. So that's where the mutation in type 3 occurs. So what does this mean? It means that, so we have some melanin because tyrosinase is functioning, but the eumelanin, this is the one that is responsible for the really dark pigment, is absent. So the patient will be having few melanin. So patients will still have some pigment, but a little bit more red or tan colored. That's how the patients will present. So this protein is also important in melanosome synthesis and melanin synthesis. We have type 4, oculocutaneous albinism type 4. This is a mutation in LCL C45A2. Okay, this is also a protein. help. They are all transporter protein. This last two, this one is also a transporter protein, and this one is common in maybe Oriental, Japan, I think, and China. So from type 1, it kind of let me just say the pigmentation kind of increases. Okay, type 1 is related to tyrosinase. We have type 1A, total absence, type 1B, reduced. You can just forget about temperature sensitive. Type 1A, total absence, type 1B, reduced. That is the TYR region. When we go to oculocutaneous albinism 2, we have the mutation is in the P protein. So these patients will have some melanin. We go to type 3, this is a transporter protein, tyrosinase related protein. So they'll have the few melanins. And we go to type 4, this is also a membrane associated transporter protein. So these are the 4 I'll be talking about for oculocutaneous albinism. Now, when we go to ocular albinism, no cutaneous manifestation, just the eye. The mutation here is in the GP413 gene. So this results in abnormal melanosomes, which have reduced motility, reduced function. In summary, just reduced function of the melanosomes. So this has been seen only in ocular albinism. This was what they discovered, that this was the problem. So that gene. So type 1 for ocular albinism, there are 2 types also. Ocular albinism, the X-linked one is called the nettle ship force. So that's type 1. They also have a type 2, which is rarer. It's a rare, that one is X-linked recessive. It's an X-linked disorder. It is rare, and the name I think is called Allen's Island, and it's one that is similar to infantile nystagmus. So I'll just go over it again briefly. Oculocutaneous albinism, ocular albinism. Oculocutaneous albinism type 1 related to tyrosinase activity. Type 1A, total absence. Type 1B, reduced function. Oculocutaneous albinism type 2 is related to PG, variable phenotypic expression. Oculocutaneous albinism type 3 is the tyrosinase related protein. Also, they tend to present either red or brown. Those are the red or brown subtypes. The oculocutaneous albinism type 4 is also a defect in the protein SLC4582. Then we have ocular albinism type 1 and type 2. The most common type 1, GP4R143, mutation. So that's for that question. Let me see. Go to that question. So I hope I was able to answer that for the person that asked.
Yes, thank you very much for the for answering the question. It was really detailed. There are a few other questions and comments in the chat box.
Yes.
Somebody talked about the differentials, the other possible differentials. It says that Waardenburg syndrome and Hallermann-Stadler syndrome are also part of the differentials. And also Chiari-Higashi syndrome would also be a differential of
Yeah, I was looking at it as just the eye. I wasn't looking at oculocutaneous.
Yes, thank you.
Thank
Then
you.
thank you for your presentation. What are the peculiarities with albinos as regards refraction?
Okay, I think one of our colleagues.
Yeah, I think somebody already talked about that.
Yes.
Yeah, and possibility of assessing them for low vision.
Vision assessment,
So
yes.
that has been addressed. Thank you very much. Do we have more questions from the audience before we call it a day? Okay. All right. In the absence of further questions, thank you very much, Dr. Christiana, for doing justice to the topic on albinism. We really appreciate your time and the efforts you put into this presentation. Thank you very much once again.
Thank you very much.
We have come to the end of today's session. We hope to see you again next fortnight. Thank you all and have a lovely weekend.
Thank you.
Bye.